Hello everyone. Today I will be talking about clinical practice guidelines for the management of hyperglycemia in hospitalized adult patients in non-critical care setting. Diagnosis and recognition of hyperglycemia and diabetes in the hospital setting. Recommendations. Recommend all patients admitted to the hospital be assessed for a history of diabetes. All patients independent of prior diagnosis of diabetes should have a blood glucose level tested on admission. Patients without a history of diabetes with blood glucose greater than 140 milligrams per deciliter should be monitored with bedside point of care testing for at least 24 to 48 hours. Hyperglycemia is defined as any blood glucose level greater than 140 milligrams per deciliter. Observational studies report that hyperglycemia is seen in approximately one-third of non-ICU patients and approximately in 75% of ICU patients. All patients with no history of diabetes or with hyperglycemia should have hemoglobin A1C level checked at the time of admission if it has not been done in the preceding 3 months. Elevated hemoglobin A1C in patients with hyperglycemia can differentiate previously undiagnosed diabetes from those with stress-induced hyperglycemia. Number 2. Monitoring hyperglycemia in non-critical care setting. Recommend bedside capillary point of care testing as a preferred method for hyperglycemia monitoring. The point of care testing should match with nutritional intake and diabetes medication regimen in the hospital. Point of care testing is usually performed 4 times daily before meals and at bedtime for patients who are eating. Point of care testing should be obtained as close to the time of the meal tray delivery. For patients who are NPO, point of care testing is done every 4 to 6 hours. Glycemic targets in hospitalized patients. American Diabetic Association and American Association of Clinical Endocrinologists recommend a pre-meal glucose target of less than 140 milligrams per deciliter and a random blood glucose level of less than 180 milligrams per deciliter for most of the hospitalized patients with non-critical illness. In order to avoid hypoglycemia, insulin dose should be adjusted if glucose levels are between 70 to 100 milligrams per deciliter. Medical nutrition therapy should be included as a component of glycemic management program for all hospitalized patients with diabetes and hyperglycemia. By providing meals with a consistent amount of carbohydrate at each meal, it can be helpful in coordinating doses of rapid-acting insulin with meals. Lack of attention to medical nutrition therapy in the hospital can contribute to unfavorable changes in the blood glucose level. Transition from home to hospital. Recommend insulin therapy as a preferred method for achieving glycemic control in hospitalized patients with hyperglycemia. Recommend discontinuation of oral hypoglycemic agents and initiation of insulin therapy for majority of patients with type 2 diabetes at the time of admission. Pharmacological therapy. Recommend that all patients with type 1 and type 2 diabetes treated with insulin at home should be treated with a scheduled subcutaneous insulin regimen in the hospital. The scheduled regimen consists of basal and bolus insulin. Basal insulin can be given in the form of long-acting insulin such as insulin glargine or insulin detamir once a day. Intermediate insulin such as NPH insulin can be given twice a day. Bolus insulin in the form of rapid-acting insulins such as insulin lispro, insulin aspart can be given 3 times daily before meals and once at bedtime. Correctional insulin refers to administration of supplemental doses of rapid-acting insulin or short-acting insulin together with pre-meal insulin for blood glucose levels above target range. The dosing of insulin is based on patient's weight. For patients aged greater than 70 years and if their GFR is less than 60 ml per minute, the starting dose of insulin is 0.2 to 0.3 units per kg of body weight. For all other patients with blood glucose of 140 to 200 milligrams per deciliter, the starting dose of insulin is 0.4 units per kg of body weight. The total calculated dose of insulin is given as 50% basal insulin and 50% nutritional insulin given before meals. The total dose of basal and bolus insulin taken at home should be reduced on admission by 10 to 20%. If a patient is not eating by mouth, the prandial or pre-meal insulin should be held and resumed once the patient starts eating. Next, transition from hospital to home. Recommend reinstitution of pre-admission insulin or oral and non-insulin injectable medications on discharge. For patients who are going to be discharged home on insulin therapy as a new medication, it is important that the patient receives education regarding the injection of insulin while he is still in the hospital. Patients and their family members should receive both written and oral instructions regarding their diabetic management regimen on discharge. Special situations. 1. Transition from insulin drip to subcutaneous insulin therapy. Recommend all patients with type 1 and type 2 diabetes mellitus who were treated with oral antidiabetic agents or with insulin therapy prior to admission be transitioned to subcutaneous scheduled insulin therapy at least 1 to 2 hours prior to discontinuation of insulin drip. In contrast, majority of the patients without a prior history of diabetes receiving insulin drip may not require a scheduled subcutaneous insulin regimen. 2. Patients receiving enteral nutrition or parenteral nutrition. Recommend point-of-care blood glucose testing be initiated for patients with or without history of diabetes receiving enteral and parenteral nutrition. The point-of-care testing can be discontinued in patients without a prior history of diabetes if blood glucose values are less than 140 milligrams per deciliter without insulin therapy for 24 to 48 hours. Scheduled insulin therapy should be initiated in patients with and without known diabetes who have hyperglycemia with blood glucose greater than 140 milligrams per deciliter on 2 occasions in a 24-hour period. 3. Glucocorticoid-induced hyperglycemia. Recommend bedside point-of-care blood glucose testing be initiated for patients with or without history of diabetes who are receiving glucocorticoid therapy such as prednisone or methylprednisolone. The point-of-care testing can be discontinued in patients with no prior history of diabetes if blood glucose results are below 140 milligrams per deciliter without insulin therapy in a period of 24 to 48 hours. Recommend that insulin therapy be initiated for patients with persistent hyperglycemia with blood glucose greater than 140 milligrams per deciliter while receiving glucocorticoid therapy. Hyperglycemia is a common complication of glucocorticoids therapy in the hospital with a prevalence around 20 to 50%. Approach of insulin therapy during enteral nutrition. For patients receiving continuous enteral nutrition, administer basal insulin, either glargine or datamir once a day, or intermediate insulin such as NPH twice a day, in combination with a short-acting or rapid-acting insulin in divided doses every 4 to 6 hours. In patients receiving only bolus feeding, administer short-acting or rapid-acting insulin analog before each bolus administration of enteral nutrition. Perioperative blood glucose management. All patients receiving insulin before admission require insulin during the perioperative period. Recommend that all patients with type 1 diabetes who undergo minor or major surgical procedures should receive either continuous insulin infusion or subcutaneous scheduled insulin regimen. Patients with type 2 diabetes, insulin dependent, should be on scheduled basal bolus insulin during the perioperative period. Recommend discontinuation of oral and non-insulin injectable agents before surgery. Postoperative blood glucose values greater than 200 milligrams per deciliter are associated with prolonged hospital length of stay and increased risk of postoperative complications. Patients with type 1 diabetes whose blood glucose is well controlled, reduction of insulin dose by 10 to 20% is recommended. For those whose blood glucose is greater than 200 milligrams per deciliter, full dose of basal insulin can be administered. For patients with type 2 diabetes, 50% of the basal insulin dose can be given on the day of surgery when they remain to be NPO. All pre-meal bolus insulin should be held when the patient is NPO.